RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers, where we bring together clinical insight, real-world experience, and practical strategies to support the care that you deliver every day. I'm your host, Amanda Mixon, president of RhAPP, and I'm so glad that you've joined us. In today's episode, we're tackling one of the most important and often most challenging aspects of patient care: ensuring that the therapies we prescribe are actually accessible to our patients. The one thing that makes me want to bang my head against the wall every single day, as it does, I'm sure, all of our listeners. From the fundamentals of Medicare formularies and coverage decisions to navigating prior authorizations, step edits, and tier placement, access is always a moving target. And with newer programs like CAP and Smooth entering the landscape, there are evolving opportunities to better support our patients, but only if we understand how to use them. I'm joined by two outstanding colleagues and friends, Heather Finlayson and Stacey Johnson, who bring deep expertise and practical frontline perspectives to this discussion. Together, we'll break down what providers need to know, how to anticipate and overcome common access barriers, and how to partner more effectively with patients to move from prescription to possession. So let's go ahead and get started. Thank you both so much. I know you've both been on RhAPPcast before, but just so that we're all on the same page in case anyone doesn't know who you are, Heather, can you introduce yourself?
Yes, I'm Heather Finlayson. I'm a PA. I work in rheumatology down in Littleton, Colorado, and I've been in rheumatology for about 14 years.
Well, thanks so much for joining us today. And Stacey.
Yeah, and so I'm Stacey Johnson. I work in rheumatology in Great Falls, Montana, and I've been in rheumatology for 5 years.
All right, let's go ahead and get started. So, Stacey, I'm going to ask you the first question on Medicare Formulary 101. So, to lay our foundation, what are the most important basics of how Medicare formularies work, and why do they matter so much when prescribing rheumatologic therapies?
So for Medicare, their formularies really are kind of their approved drug list. And so you need to be aware of those because when you're prescribing to these patients, you want to make sure that you're not delaying treatment by picking something that, number one, isn't going to get paid for or approved. Because really, when your prior auth or your biologics coordinator is working on these and you come back with a no, you have to try this or this. If you're aware of these and how they work, then at that point, you are able to expedite treatment initiation. And also knowing how it's going to affect the patient's out of cost. Because if you go with a non-formulary drug, then at that point, the patient's out of pocket can be quite a bit more expensive. You also need to know, along with their formularies, like which pharmacy is preferred so that, again, you're not jumping through multiple hoops that may or may not be the right hoops to jump through. And then you also need to be aware of which plans you're utilizing. So are you using their Part D program or are you looking at their Part B, which really impacts whether or not injectables will be affordable versus infusibles.
So, Heather, in a broad sense, what parts of the Medicare process, tiers, step edits, PA requirements most often affect access to advanced therapies, and how can providers anticipate and handle these hurdles?
Yeah, so I think kind of as Stacey alluded to, we have, Part B medications and Part D medications. And I think when I started in rheumatology, we didn't have this kind of process where we have the CAP and Smooth, which we'll discuss in a moment here. But out of pocket, like Part D medications sub-Q were so expensive, patients could not afford them. So we did a lot of Part B, which is where it's going under the medical benefit in the infusion centers. So I think that's really important to know kind of where cost is coming from. But we also know that a lot of times Medicare, straight Medicare doesn't need prior authorizations where Medicare Advantage does. So that also affects things sometimes too with site of care where patients can infuse, also buy and bill versus kind of white bagging, those types of things. Typically Medicare doesn't like a lot of white bag. And so that's something we have to think about. So I think we have to understand what kind of plan the patient has, which can be complicated, to know kind of which route to go is going to be the best way for patients to get their meds without having so many hurdles to jump through.
So, Stacey, can you unpack what preferred coverage actually really means for patients, particularly how placements on the lowest copay tier translates into practical benefits for their care and their access?
Yeah, and I think probably one of the easiest ones to look at to kind of give a real world kind of example is adalimumab, right? We have so many biosimilars now, and different Medicare plans have different preferred agents. And so what we'll see is that they get a better price when they're utilizing these preferred or top tier medications. Whereas if you go to the lower tier drugs, the patients actually end up having a higher copay and a higher financial responsibility. And as we know, patient assistance with Medicare is fleeting. It's very hard to get our patients on. And so we want to make sure that we're using the drug that has the best, it's the most affordable for our patients.
Let's try to unpack a little bit of what understanding cap and smooth are. So, Heather, can you provide a clear and simple explanation of what these are and why they were created?
Yeah, so I think this is kind of, I think, revolutionary. It kind of got rid of the donut hole, as we say. So the CAP is actually competitive acquisition program. And this is a cap on the out-of-pocket Part D medications for patients. And I think the important thing to remember here, this is not just our medications. This is all of their medications that they're getting under Part D. So our medications kind of lump in with that. And it was created essentially to then not only cap the amount that they're paying out of pocket each year, but also to smooth those payments out over 12 months. So that's really beneficial. Right now, the cap is 2,100 a year for prescription medications, which is about $175 a month. And so I think again, that makes hopefully things more affordable from that perspective.
Yeah, I mean, you kind of think about the people that probably need it the most, right? Like people that aren't working, right? They're no longer working anymore, especially our Medicare patients. And then they're being asked to, pay these astronomical amounts that they can't afford. So doing something like this obviously makes it so much more affordable for patients so they can access their therapies. So on that same note, how does this program help patients actually stay on or access their therapy?
So, I mean, just as you alluded to, I think we can actually use sub-Q medications now, right? Where before they can't get copay assistance, right, from the manufacturer, so they were having to pay thousands of dollars to meet these deductibles, and most patients, again, on these fixed incomes, cannot afford that. So it's really opened up, at least in my eyes. We're not necessarily having to do all the IV therapies. We can really move towards some of these sub-Q therapies for our patients, which are many times the better choice for their treatment.
Absolutely. I mean, when I started, it was always like if you were Medicare, all you could be on was an infusible. And, unfortunately, sometimes that's just not appropriate for the patient. And, so I'm so happy that this exists.
Mhm.
Stacey, what do providers need to know about M3P's opt in process and annual out of pocket cap for enrollees as we counsel patients on access pathways?
So for this, I think it's really important that we number one know that they're there, right? Because otherwise, the first part of the year, your patient's going to come in and be like, "Oh my gosh, this drug cost me $700 a month," and it's like, "Whoa, whoa, whoa, hold the phone." This is even a conversation that I have with patients that are 64 and about to turn 65 because for a lot of people, they're running through all these insurance plans and trying to figure out what's best. So it really comes down to making sure that your patient knows that they have to call Medicare and call their plan and elect in. Because if they don't elect it, then they do get that sticker shock at the front of the year. Now, if it's already too late and it's February or March and they've already paid it, then you say, good news. Well, you don't have to pay anymore for the year. But it's one of those things that you want to make sure that they know to enroll. We can't enroll them. So there has to be that education and making sure that they know about it. Also, make sure your biologics coordinators know about it because lots of times they're the people that are talking to patients about how expensive their medications are. And then the other thing is that if it is mid-year, you need to remember that cap and smooth, it goes to it. So say you're going to enroll in with Medicare in July, and that's when you're going to enroll in this program. That $2,100 for this year doesn't go over 12 months. It goes over 6 months. And so making sure that they are aware of that is really important because they still have that $2,100 responsibility at this point.
How should you identify which patients are likely to benefit from cost smoothing? And how do you proactively raise awareness?
For everyone, I talk to them about it because I think that even if somebody comes in with looking like they're financially stable, we don't actually know what their situation is at home. And so making it so that everybody who is going to be utilizing it is aware of the program is huge. I mean, don't get me wrong. I have some patients who say, oh, no, I'd rather just pay it at the first part of the year. But most of my patients can't afford that right at the beginning of the year. They want it spread out. And so that's really how I identify is I give everybody the option. Just like with some of the other programs, you make sure that they see it, they qualify. Because it never hurts to try to get the drugs cheaper. Like with the low income subsidiary, you want to see if we can get it cheaper because what's it hurt?
Absolutely. So, what are the key steps providers need to know to help a patient navigate CAP or smooth successfully?
We really need to identify what prescriptions that we're prescribing that are expensive, right? Because a lot of our biologic therapies, those patients are going to need these smoothing effects. Um, we also need to make sure that we're discussing with patients what their role and the cost is going to be, and then making sure that you know that you're using the Part D program because really, if they're on the Part B with the infusions, they don't really need to cap and smooth because it's going to go through the different part of their insurance. And then make sure that you're reminding them because let's face it, every year people forget there's just too many things going on. So when it comes to the first part of the year, reiterate like, hey, don't forget if you don't want to pay all this up front, then we want to make sure that we're doing that.
Let's kind of shift a little bit to supporting patient access. So, Stacey, what can clinicians and clinic teams do proactively to help patients become aware of access pathways like CAP and SMOOTH before they run into a barrier?
I think that goes back to actually knowing your formularies, right? Because when we're educated as providers as to what we can access for our patients, it makes this process so much easier because then you're not wasting time and resources to get the patients on the therapy. And then you also kind of want to make sure that you know these programs so you can be aware enough to educate them and make sure your office understands because when they get the calls saying that they can't afford things, we want to be equipped beforehand versus running around trying to figure out the information at that point. Also, there are resources lots of times in the community with Medicare specifically that when people are going to be switching to Medicare, it's hey, go talk to them, find out which medications are on their formulary. Is this treatment going to be something that's covered? Is there a better plan that might cover it? And so I think a lot of it comes to being educated and being able to have those conversations that sometimes seem uncomfortable, but they pay off in the end. And the patients, I mean, they trust us and they want to know what we know because in the end, it makes it easier on them.
Absolutely. I mean, I couldn't agree more. And I think that's why, this episode is really important. It's not, the most interesting thing to talk about, but it's something that we all need to know about to help our patients. So Heather, how do you coach patients through the process when they face an access issue?
I think, you know, unfortunately, access issues are going to come up. And so I do sometimes warn patients that, hey, if something does come up with a cost of a medication or do we have to do it at the infusion center versus at home versus, something else, I think that we have to know that we do have to pivot and they have to communicate with us as well if they hear those things on their side. And I do think that we can make better decisions, kind of like Stacey had mentioned, about there may be certain formulary things that we need to think about. We can also I think there are ways we can work around it sometimes, especially when we can send medications to potentially our offices versus the infusion center and still administer them in certain places. I've also found that sometimes the administration can be different and separate from the actual prescription itself. So even traditionally a Part B medication may be covered better under Part D and then infused under Part B. So again, there's lots of different things, but I think being aware of that and just letting them know that you're there to help them and to have a lot of communication if they hear an issue to let it you know as ASAP.
In school, we are always taught document, document, document. I mean, I still hear my professor saying that to me on rotations. But can you speak a little bit to the role that good clinical documentation plays in strengthening access requests? And what are the most persuasive clinical details that payers are looking for?
Yeah, no, I think this is again, of all things, I think I spent a lot of time documenting, and I always hear like, why are you spending so much time doing that? And I'm like, because of this kind of stuff, right? Because it makes a difference in getting our medications streamlined for our patients. And I think for me, documenting failures, what they failed is really important because when we think about those tiers or step edits that we have, if we very clearly say, hey, they have failed this because of this reason, and they failed that because of this reason, we're not going to have to sit and prove that later. And so every time I see a patient, I'm documenting those things, then carrying them forward through my notes is immensely helpful, I think, to just really prove why we're using something. Because my problem is not proving that the patient warrants some medication. It's proving which one they can skip because they've already failed it.
Absolutely. And again, my medical assistant has actually gotten me a lot better at this because she's like, Amanda, you need to put what they failed, but not only what they failed, the timeline that they have failed it as well. So even if you have to go back, 15 years to when they first took methotrexate, like you really need all of those things in that note in order to now get things covered. And so for some of our newer, providers, so important, which is why I also think it's really cool when we start with the patient because then you kind of are able to start them from the beginning of like, what you prescribed, and then it can kind of be a continuum in your note. It's more challenging, obviously, when they maybe have transferred care to you and have seen other people to try to get the records. But that is so important because, we're needing that more and more to have all of that documentation in order to get the therapy that we need. Obviously, the most important thing is partnering with our patients. So, Heather, how do you have a conversation with the patient when they're discouraged or frustrated or confused about access or cost? I mean, I have to tell you, I'm still confused about all this stuff. So, I can only imagine what a patient is thinking that doesn't have that medical knowledge. How are you keeping them engaged in this shared decision making?
Yeah, I think, kind of like we've talked about, is just making sure they're aware of what, that they can access this program, that they do have the ability to smooth these payments out over 12 months. I know sometimes $175 can be expensive for patients, but ultimately healthcare does have a cost. And so I think just setting that expectation and the fact that this does include not just the rheumatology medications, but all of their medications can be really helpful. And I think just communication is key. I keep coming back to that because again, if they'll get a denial letter and we haven't heard about it yet, and there's just like this kind of gap of just time passing of us not dealing with something. So if they can just really reach out to us as soon as they can, then we can try and pivot. And sometimes there is the ability to do a different type of therapy that will be covered. So I think that sometimes is what we have to think about too.
Stacey, do you have anything to add to that?
I think the other part of that too is also like really recognize the patient's distress, right? Because let's face it, this is a huge headache for everyone, not just us, right? It's huge for them. And so really being like, yeah, no, this is a very challenging and this is not just a you problem. This is a system problem. Because a lot of times when they're going through this and they're on the phone and they're calling 5 different people, they feel like, why can I not figure this out? And really giving like an ear to that can make them feel a lot better. And it encourages them and realizes that, okay, you as our provider have been through this. We're not alone. We can get through it.
Do these access pathways change the way that you talk about choosing therapy, Stacey? Especially when like balancing what's ideal clinically with what is realistic?
So that is a really sticky question, right? Because the technical answer that we're supposed to give is that it can't impact the way that we care, right? But on the flip side, is no care better than care that they can afford, right? And I think that that's kind of an ethical question because just because insurance says that this is best, do we agree with that as providers? And I think that's really when our advocacy skills for our patients come into play because we have to make educated decisions and realize that sometimes there's pros and cons, right? Yeah, it may not be 100%, but it's what they can get, and we can balance it other ways and try to get better disease control.
Heather, is that kind of how you feel too?
So I think for me, I think just recognizing that, Medicare will really follow PIs to the T, right? So when we're used to maybe things like with infliximab, where we can schmooze up the dose and up and down and change the intervals, with certain diseases, if it's only indicated at certain doses and certain intervals, that's what you have to do. And so I think it's just important. Again, it's just another it's a validation of the frustration sometimes, but also setting expectations for patients that, again, these are expensive medications. We want the insurance company to pay for them. We have to do what the insurance company wants to some extent, if that makes sense.
Yeah, I totally agree with both of you. All right, I want to kind of look to the future because I think that that's really important. And Heather, you in particular are kind of paving the way for advocacy for patients and providers. And, I'm so excited to see what you do with advocacy for RhAPP. But let's look forward to changes or improvements that you would like to see in the access environment to help ensure patients get the therapies they need when they need them.
Yeah, I mean, I think it's complicated because we always kind of talk about how we wish that we could practice and prescribe what is necessary for patients and not have to worry so much about formularies and what's available. I think for me too, having transparency from the perspective of the, Medicare or any other insurance company to know, again, which one should I pick first? Like if it's adalimumab, which biosimilar do you want me to pick? Because I will pick that one if I know that's going to streamline that process. So transparency is, I think, really important. And that's one of the things that I think would really help us as well.
Stacey, any last minute comments on that?
Yeah, I think the other thing that would be really nice would be cost stability, because really we got rid of this donut to make it so it was more affordable. But since we've been on the cap and smooth, our prices have gone up every year. So at what point are we going to get to this higher level where once again, we're leaving the affordability? And with the influx of Medicare Advantage plans, it's going to become a bigger and bigger barrier to care.
Yeah, because year after year, it keeps going up. Like I think now we're going up to, I think next year they're already predicting it's $2,200 a year. So again, in the 3 years this has been around, it's now already every year gone up. And that's going to at some point be an accessibility issue.
Absolutely. And I think this is why it's important that all of our voices are heard so that we can hopefully make changes for our patients. As we wrap up today's episode, I really want to thank Heather and Stacey for sharing their experience and practical insights on navigating Medicare access and programs like CAP and Smooth. I have to say I've kind of heard about these things previously, but it's just been so helpful to have both of you explain it to me. So I really feel like on Monday when I go back to work, I can actually talk to my patients about this. These are conversations that truly help bridge the gap between prescribing and ensuring our patients can access and stay on the therapies that they need. To our listeners, thank you for spending time with us. If you found this discussion helpful, be sure to explore more episodes and educational resources available through RhAPP. For easy on-the-go access to all of our digital education, including podcasts, video content, and additional learning tools, I encourage you to please download and explore the RhAPP ACE 2.0 mobile app, your central hub for staying connected with the latest in rheumatology education and resources. Thank you again for listening to RhAPPcast. We will see you next time.